Okay, we were talking about operative operations on rotator cuff tears. Here's the next case. Greg, what do you think of this case?
64-year-old sir with shoulder pain. Sorry, getting a lot of feedback. Evaluate rotator cuff tear. So we have coronal images here. Looks like there's quite a bit of irregular signal within the supraspinatus tendon. Um, uh, so it
Here.
looks like there's a tear there at the humeral insertion.
Okay, so we have a tear here and probably a lot of tendinosis more proximally. We'll come back to a little bit. So this is 6/24, 2020. And so this is read as an insertional supraspinatus tendon tear. So now we go to 7/16, 2020. What do you see here?
So it looks like there's post-surgical changes from a prior cuff repair.
Okay,
Um,
so at this time there really weren't changes there. He had had no surgery. He then had surgery around 6/28 or something like that. And then he came back on 7/16, 2020, after having been repaired. What do you think here?
I see the suture anchor there inferiorly,
Okay.
but it doesn't look like maybe the construct has failed.
Okay.
I don't.
So on this one cut, what we see is a distal row, but we're not seeing the proximal row of the double row repair because we're just not cutting through it. But what we see here is what looks like a persistent tear here of the supraspinatus tendon, and we still see that tendinosis of the more proximal tear. So this we just did just because of our own curiosity to follow up. Uh, this is Dr. Stone's shoulder. And we looked at it. We were a little concerned that the tendon was not brought all the way down to the bone like in this particular case, and he got some opinions from elsewhere and decided to have his friend reoperate on this because he was having pain at that time. But let me tell you, a month after surgery, everybody has bad pain. From my own experience. So now he's having increasing pain. So he went back and had a second surgery. And this is after that second surgery. What do you think?
So after the second surgery, it looks like there's still tendinosis within the supraspinatus tendon, but it looks like there's a little bit more integrity of the
Okay.
repair at the humeral insertion. There might be a little bit of increased signal along the lateral aspect, but
Mm,
Here.
what I see is that the tendon has been there's an attempt to pull the tendon into a trough. The way I described it the other day, what I do, I make a trough and get a better bone contact to the tendon. Uh, this looks something like that, but
Okay.
I'm not sure that. Well, you're more experienced with this, obviously, John. So, do you think that's
Yeah,
connected there distally, or
right. I do think it's connected distally. And they shored this up. This is only a day or two after the second surgery. And they made sure that they brought that distal end tendon down to the bone so you could start getting bone tendon healing. So this is on 8/13/2020. So we then did the MR scan on Dr. Stone's shoulder for kind of every month for a while. This is what we saw on 10/8/2020. What do you think here, Greg?
so still seeing kind of heterogeneous signal throughout the tendon, so there's still probably residual tendinosis. There in that area, um, at the humeral insertion, it looks like there might be some fibers there, but it doesn't look like it's completely healed. It may be some scar developing.
Yeah, and we're only a few months out from surgery, so it takes time really for the scar down and have the bone really grow into the tendon. Here it is a month later. What do you think at this time?
Mm, it looks like it's filled in a little bit more, but it doesn't look like it's completely adhered to the bone.
And what about the rest of the tendon?
Rest of the tendon still looks tendinotic.
Yeah, what do you think's going on here?
Um, and that doesn't really look like there's a lot of subacromial spurring, maybe a little bit, but I don't think there's any impingement. But there is increased signal along the articular or the bursal surface.
Yeah.
Um, so yeah, so it could be a little tear there.
So he's developing more pain, and this is called a type 2 tear. This is a tear more proximally within the tendon, which is usually ascribed to over tensioning the tendon at the time of surgery, putting stress, and we already know that this part of the tendon is tendinotic. So by over tightening the distally, you can induce strain in the tendon here, which can lead to more proximal tears. And then here is, so this was, whoops, gotta go. Okay, this is 11/12/2020. We then kind of kept following him. He still was symptomatic. And then this now is 7/15/21. So we're about 6 months later. At this time, his symptoms are a little bit better, but you can see the area where he's got all this tendinopathy and a tear. But notice distally, it actually filled in and uh, uh, it actually really scarred down to the anchor. Here's 7 months after that. So we can see his symptoms are improving a little bit, but we can still see that he's got a high-grade partial tear more proximally in that location. So the problem, so it gets kind of tricky with these tears, especially ones like I had, which we'll see again in a minute. When they get more chronic and you get retraction, if you actually bring that tendon all the way down to the foot plate, you can overtension the tendon. And since almost, as we all know, all of these tendons that tear have underlying tendinosis first before they tear, that you risk, if you overtension it, getting these secondary, more proximal tears. So often, it might have been better if we just left it the way it was at the beginning, not reoperated and brought the end of the tendon down to the bone, because as you can see here, that distal end may still fill in with scar tissue, and we're less likely to overtension it and produce the type 2 tear more proximally. At this time, Dr. Stone said he was never going to have another surgery on his shoulder. And then a couple of years later, when I told him I was going to have surgery on my shoulder, he said, "Are you crazy? Didn't you learn from my shoulder?" But anyway, so this is called a type 2 tear, where you have a more proximal tear. So just to remind you, this is what I looked like back when I was asymptomatic, younger. And we can see that there's a little bit of tendinosis in the tendon, but it's completely intact back in 1989. Jump forward to 2007 when I was symptomatic after a body surfing injury. I can see pain, probably a full thickness tear here, a little bit of scar in situ, bridging across the tear site. 2007, and this is that anterior insertional tear, which is where the vast majority of tears start. And rotator cuff at that particular time, started physical therapy. The symptoms actually started getting better. The surgeon and I decided that not to have surgery. And as long as I kept doing physical therapy, actually, it was asymptomatic, surprisingly. Here is much later. We can see that there's a little scar in situ developing, and it's not really retracting too much more at this particular time. And I went along doing fine with physical therapy, a little bit more scar in situ developing across that location. But then again, this is not strong tendon. This is really not very functional tendon. But if it keeps the tendon in relatively good place, then as I believe the primary function of the supraspinatus tendon, and this would not be the correct answer on any exam, is really to as a depressor of the humeral head. it attaches to the greater tuberosity here, pulls over here, and when it tensions, what it does is it produces a depressive effect upon the humeral head. And that's why when you see almost always with superior migration of the humeral head, that's in the presence of a long-standing massive supraspinatus tendon tear, because the tendon is no longer there to press down on the humeral head. The rare incidences where I've seen superior
I'm sorry to
migration
interrupt.
with an intact supraspinatus tendon is when people have large acromioplasties, and then the supraspinatus tendon will go up with the humeral head and may still intact, but if the acromion's here, it's not strong enough to keep the humeral head in normal position. John?
Yeah, the acromion, if you look at it, the distal inferior, it looks like it has a osteophyte, and
Little
the
one.
attachment of the deltoid is has an increase in signal.
Yeah.
And then your tendinous junction to the muscle is also problematic in one way or another.
Yeah, this is probably fat
Based on
in
that
here because it
image,
suppresses. Yeah.
um,
Okay.
and, I think that prominence in the acromion should have been removed. But
Yeah. Yeah.
that's the call of the surgeon at the time of surgery.
Well, it hasn't been operated on at this point, John.
Yeah, I know, but let's see what happens.
Yeah. So at this time, I was back to full exercise and was asymptomatic, to remind everyone, but we can still see that there's really a full thickness tear with a little bit of scar in situ in that particular area, but it was not symptomatic. Later, I had this is just follow up showing still asymptomatic with scar in situ in that location, but still there's a full thickness tear there. Okay. And then jump forward another 9 years. I started developing increasing symptoms. At this point, we can see that there's a lot of kind of edema in that area where there's scar in situ. There's persistent retraction of the musculotendinous junction. So this is all scarring in where the tear was before. And we can still see that there is a tear with this being scar tissue in here where that was. And then I started developing pain even with working out, which hadn't been before. And if you notice here, there's a little bit more proximal retraction of the musculotendinous junction, really a new tear, and this, well, a bigger tear in the area where the tear was before. A lot of that scar tissue has now torn, and there's more retraction of the musculotendinous junction in 2022, and then decided to have surgery. I think this is a day after the surgery I had last year, and we can see this large tear in the rotator cuff. We can see all this fraying of the biceps, which we talked about before, which we can see on the MR scan as well. This is where they're getting ready, putting in all the different suture anchors and the double row technique, and then they draw it all closed with the sutures and close it down as we see here. And this is what it looked like the day after surgery. And then here we can see there's still proximal retraction of the musculotendinous junction, so there was not an attempt to bring the tendon all the way back to its normal position. Again, the concern there is what would happen would be a type 2 tear like occurred with Dr. Stone. And then, as you saw, I followed this out over time. We could see the biceps tenodesis. If we followed this was the biceps tendon, we could follow it down. It was intact. We also could, this was a suture anchor over to the superior subscap repair, and the subscap looked intact at that particular time. Here's the subscap repair with a lot of scar tissue in that area. Then in following it over time, 1/4/23, this is 3.5 months afterwards, and I've been following this, and now we can see that there really is a tear, probably really at the junction between the distal end of the tendon and the repair site on the supraspinatus tendon. At this time, I had a shoulder pain, but it was getting better after surgery, and I think it was all post-op pain. 1/4/23. Go forward March 22nd. We can see that we still have that tear in that location. The suture anchor from the double row technique. So this is really a tear, probably right at the proximal junction of the distal tendon there. But we can, if we follow this down, that's the biceps tendon, which is still intact. The subscap anchor, the subscap repair looks fine. And at this time, I was pretty much asymptomatic on March 22nd. And then just recently, at the 1-year follow-up, again, I did imaging, and again, we can see that there's that tear just proximal to the repair is still there. The amount of proximal retraction is about the same as it was before. Totally asymptomatic at this particular time. The biceps tendon is nicely intact here at the biceps repair, and the subscap superior insertion is intact. So, and then
What exercises do you do, John?
I do pretty much everything, though I do not really strain doing overhead exercises, but I do pretty much bench presses, which I couldn't do really before, probably because of the subscap tear. And I can do curls, so the biceps is fine. I just limit doing straight overhead exercises.
That's good.
Yeah.
What I tell my patients, or I used to, is work on the latissimus dorsi. That to me is the tendon and muscle that you have to really work on.
Yeah, you told me that, so that's what I've been doing. Yeah, following your advice. Okay.
I think of all the exercises to do, that's the one you've got to.
Good.
I've had a tear for over 40 years, and that's my. Whenever the pain comes, I start doing the exercise, goes away.
Excellent. Thank you. So moving on, for these post-operative supraspinatus tendon tears, there is an article in Arthroscopy where they graded the tendon tears, or they graded the post-op tendon with or without a tear. Type 1 is normal thickness, but you just have high signal intensity. A type 2 injury is normal thickness with areas of increased signal intensity. Oh, I'm sorry. Type 1 is normal tendon. Type 3 is thickness less than a half of what the normal would be without interruption. Type 4 is full thickness interruption or 1 or 2 slices. And then type 5 is a much larger tear. I don't know anyone who uses this grading system, but it was one described in Arthroscopy in 2005. I don't use it.
Neither does Campbell's.
Okay. So if we look at MR factors and looking at postoperative tears would tend to correlate with poor outcomes. If you have a tendon retraction greater than 2 centimeters, it's associated with increasing breakdown of the construct. If the acromial-humeral distance is less than 8 millimeters, that has a high association with re-tear. Again, that the acromial-humeral distance is primarily a measure, I think, of a long-standing supraspinatus tendon insufficiency. I do not believe that the narrowing of that space actually is a major factor in directly injuring the tendon. It's really the other way around. That space is narrowed because the tendon is insufficient and isn't providing its primary function of depressing the humeral head. But I don't think that is the standard teaching. And then if you look at anterior-posterior dimension of the tear and the degree of fatty atrophy within the muscles, the yellows are independent factors associated with poor outcomes. These two are really not independent, statistically independent factors which correlate with poor outcomes. And I'm surprised that the AP diameter is not. And then this, and we have some other papers that I think I've already presented, where the degree of fatty infiltration in the muscles did not seem to be an independent factor of poor prognosis, which is different from the early papers about muscle atrophy. So let me see here. Tayson, well, what are the preoperative MRI shoulder findings which have been shown to be associated with the 1-year outcomes?
As in negative outcomes?
Either negative or positive, but let's just say negative outcomes. What do you look for in an MR scan, which is a bad prognosis for 1-year outcomes?
I would guess the degree of retraction and the degree of tendinosis of the tendon.
Okay. So what they found were poor outcomes in patients with tears is the width of the tear, which actually is not in agreement with the last study that I just showed, the amount of tear retraction, the larger the most, and then the degree of tendon degenerative signals. So these seem to be independent risk factors for poor outcomes on the MR examination. And these were MRs of people with supraspinatus tendon tears, and these were the findings before surgery.
Okay.
And what they found was no association with poor outcomes from surgery, was the degree of muscle atrophy or the amount of muscle fat within the muscle. So, and if you think about it, if it's a weak muscle, it's probably not going to pull on that construct, so it may not pull apart the construct. So, anyway, so John?
Well, I was going to say, what's the function of these people? That's
Yeah. They didn't look at the function. They looked only at 1-year outcomes as to whether they had tears of the construct.
MRI, right. The important thing to me is the function.
Sure. Right. I agree. Okay. But these are radiologists. We also don't have that data. So the next one here, let's see, Elior, when do most tears occur after surgical repair?
Um, I would think pretty soon after surgery, if you're waiting for that tendon to
Okay.
bind with that bone.
So most occur between 6 and 26 weeks. And probably they don't occur before 6 weeks because before in the first 6 weeks you're in so much pain after you have these surgeries that you don't move a muscle around the shoulder, and at that particular time, if there were a re-tear, there's so much pain in that the tear is going to cause less pain than the actual surgery. So you're really not going to probably evaluate it at that time. So it's usually between 26 and 26 weeks, and it's thought at 26 weeks you start getting enough repair where the actual construct is at less risk. So people tend to like to delay really strong exercise until the half-year time. So if people are athletes and they want to go back into sports activities, you want to be pretty careful between the 6 and 26 weeks. Again, you don't have to worry about the first 6 weeks because they're so much pain they're not going to do anything.
That's about the time that the sling is removed.
Is that right?
And exercises are starting, and that's precisely the time when healing has some progression. Up to this time, the healing has not been that profound. It takes quite a while for that tendon to attach to the bone. So 6 weeks is just about the time when it's starting to attach, and you take the sling off, and you never know what people are going to do.
So yeah, generally around 6 weeks, it's still pretty painful, but they like to start kind of motion exercises, but passive exercises, not active exercises, and not really put in full active exercises till you get up around the 26-week period.
And physical therapy, if you have an aggressive person doing it, they'll contribute to this problem.
Okay, right. Okay, Robert.
All right, we have one second. Okay, so we have a 35-year-old with shoulder pain, and it looks like there's a tear at the foot plate of the supraspinatus. Yeah, pretty high grade.
It's either full thickness or near full thickness. You know,
Right.
maybe some of the surface of the joint side may still be intact. So this is one of those that could be essentially a full thickness tear, but might be difficult to see by arthroscopy way out here. This is on 2/25/2011. Okay, this is on 11/22/2011. So we're going from February to November. So what do you see here?
All right, so it looks like they've had a rotator cuff repair.
Right.
Like there may still be some tearing of the supraspinatus, kind of interstitial there. Yeah, and then not sure what that's inside of the joint.
So they had persistent pain, or pain at this time, and this was thought to be a tear adjacent to the construct, maybe not the construct itself. And I think they elected to treat this conservatively and not reoperate on this, but they cut back physical activity.
That looked like a very easy one to fix. I don't know why the anchor is where it is. That's kind of a
Yeah, this was a single row technique.
yeah, I know, but I don't think the anchor is in the right place.
Okay. Alrighty. Okay. Greg.
75-year-old male, single suture anchor repair 3 years ago, placed at base of greater tuberosity because the tendon could not be stretched. So I do see, it looks like 2 suture anchors on the coronal view, there and there. That
Yeah,
the
this is-
most superior suture anchor looks a little irregular. It looks like it's not even in the bone.
If this is suture anchor, it's out of the bone. This is probably metal associated with
That's in
the
a
design of
joint.
the tendon. Yeah. And here we can see.
Some susceptibility artifact associated with the suture anchors.
Yeah. Here's some other images where we can see. And then, oh, right. This is this was actually, they placed a suture anchor very proximally here, and right in through here is where that suture anchor went. These aren't the best images to show that. And they actually put the suture anchor through the articular cartilage here. This patient had significant limitation of range of motion, couldn't abduct the shoulder well, because you could see if with just a little bit of abduction, this area of the articular surface is going to come down into the glenoid. So this patient had significant limitation of motion and had a very proximal insertion. So now we'll talk about other treatments for this rather than trying to implant the tendon very medially here. This one ended up not doing well.
I don't know why anybody would. Well, I do know, but obviously they're not knowledgeable in what they're doing. You don't put an anchor in the middle of the head.
Yeah. So so let's now go on to talk about massive rotator cuff tears. And this is a situation where you have massive, most of these are long-standing. If they're really acute massive tears, then they're typically treated in younger people. They're typically treated with multiple suture anchors in the standard way. Most of the massive rotator cuff tears are in older individuals that have had long-standing tears and a lot of degenerative disease of the tendon. And what they primarily suffer from is pain. They have limited range of motion and function, but they've learned, usually by the time they come in, they've learned to live with that. So the main purpose of these surgeries for massive rotator cuff tears is more pain control. And you can have patch graft, you can do superior capsular reconstruction, muscular tendinous transfers, and subacromial spacers. And then, I don't know, let's forget that. So, so patch grafts are situations where the tendon, if you try to bring the tendon down to attach it to the bone, the tendon is not long enough, and you would put too much strain on the muscle like we've been talking about. So what you can do is bring the tendon close and then put a patch graft in to bring it all the way down to the tendon. And some of these can be really large, but a patch graft is fixed between the greater tuberosity and the distal end of the tendon itself, as opposed to some of the other grafts we're going to talk about this. So if the tear is not too large, you can try suturing to the tendon, but these graft tendon interfaces tend not to heal all that well. Another one is called a supracapsular reconstruction, and here what you have is a massive tear, and you bring in a graft, but here you suture the graft to the greater tuberosity and to the muscle tendons on either side, but instead of suturing it directly to the supraspinatus tendon, you actually suture the graft to the superior glenoid. So this basically then is a biologic spacer between the humeral head and the acromion process, which basically then is thought to function similar to the supraspinatus tendon, and it tends to restrain superior migration of the humeral head, and therefore less bone-on-bone contact with the acromion process. And surprisingly, at first people thought that these would just wear away immediately between the humeral head and the acromion process, but actually they tend to be relatively stable over time, and they are relatively effective at decreasing pain in these individuals, probably because they help stabilize the humeral head. And then another way is called a subacromial spacer, where instead of putting in a cadaver graft across through here, you actually put in a little balloon that you blow up to act as kind of a pillow cushion between the humeral head and acromion, again functioning to restrict superior migration of the humeral head and direct bone-on-bone articulation. So those are the surgeries that are attempted now, and the one that I see most commonly in this area is the supracapsular reconstruction. And we followed a couple of those that tend to do well over at least a several-year time period. Okay. Elior, what do you think of this one?
Okay, a 69-year-old male, 30-year history of metalworking and pain. I see a full thickness supraspinatus tear with retraction.
Okay, there you go. There's the distal end of the tendon. Retracted back about probably 3.5 centimeters. This was on January 11th, 2013. Now we're up in November of 24th, 2017. So this is a few years later. What do you see here?
I see some metallic artifact in the deltoid muscle. The supraspinatus, I'm seeing some intact fibers distally. proximally, I mean, is that some retracted tendon there?
Yeah, here's the musculotendinous junction way back here. Let's come
Mhm.
back here. Back pretty much where it was before. We don't really see anything over the humeral head here. But then now we're seeing some stuff here over the humeral head, but
Mhm.
there is still superior migration and narrowing of that joint space. The patient had increasing
Not
pain.
John, that was not a functional supraspinatus,
No,
or I should say rotator cuff, because we don't know. Probably the infraspinatus is torn too.
that the infraspinatus was torn. That's right. And they usually are on these massive tears. So this was on 11/24/2017. They had attempted a repair. It obviously broke down at this particular point. So now what do you see?
Here, so now there's some new suture anchors. Looks like double row. I see I think it's supraspinatus tendon, this black signal.
Um,
What's this?
No.
Is this
Right,
what you're
that's what I'm
talking about?
looking at. Yeah, I'm not I'm not sure what that is.
Okay. So,
maybe scar.
yeah, this is a graft.
Uh-huh.
This is a
Okay, the
supracapsular
same thing.
reconstruction. They tacked it down here, and they actually then tacked it down to the superior glenoid. And so this is what a supracapsular reconstruction looks like.
So that's just to prevent from the acromion
Yeah.
pinching on the head,
Yeah, it's a
preventing
prevent that.
pain, basically.
Yeah.
This is-
See, here's the way it was
I don't
before.
think those last.
You can see edema here in the chromium process, and then now you still see edema in the chromium process, but here we can see the supracapsular reconstruction. So,
How old is this patient, John?
not young, but I don't remember the age. Let me go back and see. Oh, there it had 69 years old.
69. That's a uh, reverse prosthesis is the way to go on this one.
Eventually.
A total replacement.
Yeah.
That's not going to work, whatever they did there.
Well, we'll see. I don't know what the longest term follow-up has been on these, but I've seen a few of these that have at the 2-year time period there where they still look good. So I don't know what the
2 years is about the time that they fall apart.
Okay. So I haven't seen any good studies looking at longevity in these, and I think the surgery is relatively new, so it may take a few more years to know that.
Yeah, well,
Yep. Okay. And then this is just shows when you can't repair the cuff, you can do this the reconstruction technique, which is the one we just saw. And again, you can either suture the proximal in here to the bone or to the tendon, and they're just called two different things depending on where you suture to. But the bony reconstructions, I think, tend to be a little bit more foolproof. The soft tissue doesn't work reliably as well as graft to bone.
I don't think bone will grow into that tendon and connect. So
Okay.
if it does, that's great. But
Yeah.
that, that's like a pad between the two bones.
Yep. Okay, so Robert, what do you think of this one?
All right, so we have a 15-year-old with a sports injury 1 week ago. It looks like there's a lot of edema kind of at the insertion of the teres minor.
Right.
Yeah. Again, I see a lot of edema, maybe a tear of that teres minor.
Yeah, so this was an acute teres minor tear, which I don't see very often. It's a pretty unusual injury. Okay. Tayson, what do you think of this one?
All right, so we have the axial PD fat set of the shoulder. It looks like, yeah, we have a fluid gap right where I think the teres minor tendon should be, right?
Here's the teres minor muscle, the tendon coming through here. Then we got fluid over here, probably in the posterior subacromial subdeltoid bursa. We can see some of the suture anchors there. This would be the tenodesis. But what do you think of the muscles?
What do I think of the muscles? I think the volume looks okay.
What do you think of the anterior deltoid muscle?
Anterior delta, it looks like there's some increased signal.
Right. So there you can see
Well, it's been stripped.
Yeah, and this was a acute denervation atrophy after surgery in this particular patient.
And
Okay.
axillary nerve has been compromised.
Yeah, peripherally there. Greg, what do you think of this one?
Pain and weakness after 4 prior surgeries. So we have multiple coronal views. Looks, I don't really see, it looks like, there's a dark kind of structure, or hypo-intense structure, yeah, overlying the, so is that a prior graft?
Right, that's a
Here?
graft, and this is the deltoid, and this is
That's
basically ended up being deltoid dehiscence, and this is a very difficult thing to treat. And the deltoid is really essential for really raising the shoulder. The supraspinatus, as opposed, I think, is primarily to depress the humeral head, but it's not usually listed as a humeral head depressor. A lot of people say that the importance of the supraspinatus is raise the shoulder up to just short of the 90-degree position, and then from then on, it's the deltoid which is responsible for raising the shoulder. So the deltoid is really an important muscle for function of the shoulder. And when it's torn, which used to occur postoperatively because one of the approaches to the shoulder was taking down the deltoid, but the deltoid doesn't heal very well, so there are a lot of complications to that. And whenever you see a lot of degenerative disease in the shoulder, you always have to comment on the deltoid because the deltoid is necessary for all really total shoulder arthroplasties. So if you don't have an intact deltoid, you really limit the surgical possibilities of patients with severe disease. John?
Well, the deltoid, if you tear it, you can't suture it because it's all muscle. Now, the area of attachment to the chromion is there is just enough tendon between the bone and the muscle to be able to suture it if you're if it's not too distal. I mean, proximal in terms of the deltoid muscle. So you can suture it back, but you have to be knowledgeable and prepared to do this to get vision before arthroscopy. That was a common problem. So, but when you take the deltoid down, for some reason, to get more view, you have to take subchondral bone with a tendon, and then you can usually get away with it. And I didn't say always, I said usually.
Thanks, John.
But in this situation, it's just I don't know what they did.
I don't know any more history on this one. Okay, Elior. Wait, Greg, you did the last one, right?
And that's a very powerful muscle because that's the main abductor. Your supraspinatus initiates your abduction, but the deltoid is also working at the same time,
Yeah.
except the deltoid increases as your arm goes up. The deltoid takes over more and more, and the supraspinatus doesn't. At 90 degrees, supraspinatus isn't doing very much.
Greg, did you do the last one?
Yes, yes, you did.
Elio.
It's I have a question about the previous case. Is the issue here that deltoid is in the wrong place? The lateral head has been moved more distally?
It's a
Yes,
pulse.
I mean,
Right, okay.
it's no longer functional here because it's not at the proper length to be functional. So
Okay.
this is
It's
really
just
not a functional
bunched up.
repair.
If you look at below the greater tuberosity, the muscle is bunched up, so it's not doing anything.
So if the muscle
It's
retracts
like
here, it's not going to raise the humerus.
I
no
see.
way. And then that scar tissue from there down, and that's as you can see, it's just a wiggly line kind of thing. That's a non-functioning shoulder, basically.
I see. Okay, this case, 84-year-old female with chronic pain, rule out rotator cuff tear. So the supraspinatus, I'm not seeing the fibers well. I'd be concerned for a tear,
Okay.
a full
The
thickness tear.
supraspinatus is torn.
Um, and looking at the deltoid muscle, I'm not seeing a deltoid
Right.
laterally. Could it be a
So,
similar case?
so I just want to remind people, when you see a supraspinatus tear, don't just get fixated on that. In this case, probably the more significant lesion here is the deltoid tear rather than the supraspinatus tear. And here you can see that there's no deltoid tendon over there and all this fluid in the area of the deltoid. So this was both torn, but the more devastating of the two injuries is the deltoid tear, not the supraspinatus tear.
No question about it.
Okay. Robert.
All right, so we have a 75-year-old with shoulder pain, no infection. The tests were negative. Looks like there's been a prior supraspinatus repair. There's a lot of edema in that humeral head with some, I guess, widening of the space around the anchor.
Yeah, there's a PD fat set or stir probably. This is probably a stir sequence. Okay. So what do you think's going on here? Patient has a lot of pain.
Well, it does look like there's at least some partial tearing of the supraspinatus there with some retraction, some subacromial, subdeltoid bursitis, but
Fluid there.
And that bursa is full of fluid, and
mm-hmm.
I still would not rule out an infection.
Yeah.
Would you, John?
Well, I if I saw this, the first thing I would think of is infection, and then, but they did a lot of aspirations, and they were negative, and this turned out to be a foreign body reaction to the suture anchor.
Oh, no, that's okay.
Yeah.
That's not well, obviously that's not a metal.
Yeah, these were the old suture anchors that they don't use anymore
right,
now,
got it.
where foreign body reaction was not an uncommon problem. Yeah, good. Okay, Tayson.
All right, so it looks like there's been a rotator cuff repair with the anchor at the humeral head. It looks like a lot of widening within the tunnel with fluid. Yeah, and then there's a extensive fraying of that distal supraspinatus tendon next to the anchor.
Yeah, and these are what those old anchors look like on an MR examination. So this is another suture anchor cyst due to reaction to the suture anchor as a foreign body in a different patient.
In a situation like this, you don't necessarily need an anchor, and
Okay. Yeah, I haven't seen this problem.
And another thing is it's quite a bit of it looks like it's in the head.
Okay.
Or too close.
Yep.
Well, I've removed part of the head to get more length for the supraspinatus and got away with it, but
Okay.
you can't always do that.
Yeah. Okay. Greg.
So we have two coronal views. It looks like there's been prior rotator cuff repair. I see one intact suture anchor there. It looks like there's quite a bit of signal in the supraspinatus. It looks like there's probably some retraction too, so there's probably a full tear.
Yeah. Let's go tendon junctions back here. This is probably the distal end of the tendon there. Okay.
And then looks like there's a round hyperintense signal. So is that the other suture anchor?
That's
Yeah.
that suture
Yeah.
anchor that pulled out and displaced proximally. Again, these
I
were
think it's more common in women that are osteoporotic.
that could be. Yeah. And these were some old resorbable type suture anchors, and occasionally they would dislodge early. Yeah. Okay. Elior.
By the way, they're not always easy to find. I know a case back in the desert when I used to go there to play golf. There's a pretty good surgeon there, well trained, and he did the third operation on this lady, and she was osteoporotic, and the anchor pulled out, and he went back to try to tag the tendon down in place. That worked, but he couldn't find the anchor,
Wow. Wow.
and she was pretty much asymptomatic, so
Good.
she wasn't going to have another operation to look for it.
Maybe this is her. It's not. I'm joking.
I don't know, John. I don't think so, because that anchor was floating around someplace.
Yeah. So let's see. Who's next?
Me, Elior.
Oh, Elior. Okay.
Hey, so here we have, I'm seeing something in the inferior joint space. I mean, could it be a suture anchor?
Yeah, right there. Yeah, that was a loose suture anchor, just like John was telling us about.
Yep.
So
And that doesn't mean that you're going to find it.
yeah,
It's down there, but that's you can only put your scopes in certain places.
yeah,
That is very close to the axillary nerve. Actually, it's not that far away.
yeah. Okay, well, why don't we stop here and we'll pick up again of rotator cuff disease tomorrow.
Repair looks pretty good though.
Yeah, the repair looks good. Yeah, I don't remember what was repaired here or where the source was. Okay.
Some tendinosis, I guess.
Yeah.
Well, see you guys tomorrow.
All righty, John. Thank you.
Thank you. Have a good afternoon.
All righty. Bye.